Here are important dot points for asthma, chronic obstructive pulmonary disease, COPD, and croup, drawing from the provided sources. Asthma. Definition. Asthma is a common chronic disorder of the airways. It is complex and characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation. Obstructive pulmonary disease, COPD. In clinical practice, asthma is defined by the presence of excessive variation in lung function, variable airflow limitation, and respiratory symptoms, e.g., wheeze, shortness of breath, cough, chest tightness, that vary over time. In young children where lung function testing isn't feasible, asthma is defined by the presence of variable respiratory symptoms. Untreated asthma is usually characterized by chronic inflammation involving many cells, airway hyperresponsiveness, and intermittent airway narrowing. It is a chronic inflammatory disorder where mast cells, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells play a role. These episodes of wheezing, breathlessness, chest tightness, and coughing are usually associated with widespread but variable airflow obstruction that is often reversible either spontaneously or with treatment. The inflammation also causes an associated increase in existing bronchial hyperresponsiveness to various stimuli. Reversibility of airflow limitation may be incomplete in some patients. Etiology. Asthma does not have a single cause, but various environmental and genetic factors contribute. Contributing factors include a family history of asthma or other atopic conditions like eczema or hay fever, especially if a parent or sibling is affected. Childhood bronchiolitis caused by respiratory syncytial virus, RSV, or parainfluenza virus. About 40% of children exposed to these viruses continue to wheeze or develop asthma later. Exposure to tobacco smoke, particularly if the mother smokes during pregnancy. Premature birth and low birth weight. Occupational exposure to plastics, agricultural substances, and volatile chemicals such as solvents. Asthma is more prevalent in industrialized countries. A body mass index, BMI, of 30 kilograms per square meter or more. Bottle feeding, breastfeeding may reduce the risk of wheezing illnesses. Environmental and cultural changes, such as modifications in housing, increased air pollution, and a more hygienic lifestyle that reduces early exposure to allergens. Two key environmental factors identified are airborne allergens and viral respiratory infections. Early life exposure to dogs and cats might protect against asthma in some cases. Sensitization and exposure to house dust mites and alternaria are key factors in childhood asthma development. Cockroach allergen exposure is a significant cause of sensitization and a risk factor. Symptomatic rhinovirus infections in early life are emerging risk factors for recurrent wheezing. Conversely, some early life respiratory infections, including measles, RSV, or repeated viral infections excluding lower respiratory tract infections, may protect against asthma development. The hygiene hypothesis proposes that early life exposure to infections influences the immune system towards a non-allergic pathway, potentially reducing asthma risk. Air pollution is debated but may be linked to allergic sensitization. Heavy outdoor exercise in high ozone areas was associated with a higher risk in school-aged children. Higher pollution levels are linked to increased exacerbations and emergency visits. Low intake of antioxidants and omega-3 fatty acids has been observed with asthma, but a direct causal link is not established. Pathophysiology. Asthma is typically driven by immunoglobulin E, IgE, and triggered by an allergic reaction to an allergen. Initial allergen exposure leads to sensitization and the creation of allergen-specific IgE antibodies that attach to mast cells. Upon subsequent exposure, the allergen binds to IgE on mast cells, releasing inflammatory mediators like leukotrienes, histamine, and prostaglandins, which cause bronchospasm and trigger an asthma attack. If untreated, eosinophils, T helper cells, and mast cells migrate into the airways. Excess mucus production by goblet cells, increased airway tone, and hyperresponsiveness narrow the airway. Chronic inflammation over time can lead to airway remodeling. Airway remodeling results in bronchial smooth muscle hypertrophy, new vessel formation, and interstitial collagen deposition, potentially causing persistent airflow obstruction similar to COPD. Bronchoconstrictor is the primary physiological event leading to symptoms, characterized by airway narrowing and disrupted airflow. It involves rapid contraction of bronchial smooth muscle in response to stimuli like allergens and irritants. Allergen-induced bronchoconstrictor is mediated by IgE-dependent mediator release from mast cells. Aspirin and NSAIDs can trigger airflow obstruction via non-IgE mechanisms involving mediator release. Exercise, cold air, and irritants can also cause obstruction, with mechanisms less understood but often linked to underlying inflammation. Stress may contribute to exacerbations, possibly via pro-inflammatory cytokines. As inflammation progresses, additional factors restrict airflow: edema, increased inflammation, excessive mucus, and thick mucus plugs. Structural changes occur, such as enlargement and increased number of airway smooth muscle cells, hypertrophy and hyperplasia. These changes may not respond to standard treatments. Airway hyperresponsiveness is a significant feature, involving an exaggerated bronchoconstrictor response to various stimuli. Its severity often correlates with clinical asthma severity. Inflammation is a major factor influencing airway hyperresponsiveness. Airway remodeling can lead to partially reversible airflow limitation and permanent structural changes. These changes are associated with progressive lung function loss that current therapies may not fully prevent or reverse. Remodeling involves activation of structural cells, leading to permanent changes that increase obstruction and hyperresponsiveness, potentially making patients less responsive to treatment. Structural changes in remodeling include thickening of the subbasement membrane, subepithelial fibrosis, hypertrophy and hyperplasia of airway smooth muscle, proliferation and dilation of blood vessels, and hyperplasia and hypersecretion of mucus glands. Inflammation involves interaction of various cell types and mediators with airways, leading to bronchial inflammation and airflow limitation. Inflammatory cells include lymphocytes, Th2 cytokines, Illinois 4, Illinois 5, Illinois 13, are crucial, explaining IgE overproduction, eosinophils, and hyperresponsiveness. Mast cells release bronchoconstrictor mediators like histamine, cysteinyl leukotrienes, and prostaglandin D2. Activated by allergens via IgE or osmotic stimuli, contributing to exercise-induced bronchospasm. Increased mast cells in airway smooth muscle may link to hyperresponsiveness. Eosinophils, increased numbers are common in airways of asthmatics, containing inflammatory enzymes, producing leukotrienes, and expressing pro-inflammatory cytokines. Higher counts often correlate with more severe asthma. Neutrophils, elevated in severe asthma, exacerbations, and smokers. Their exact role is unclear but may contribute to poor corticosteroid response. Epithelial cells play a significant role. When infected or exposed to mediators, they produce mediators or sustain damage. Repair following injury may be abnormal, exacerbating obstructive lesions. IgE is the antibody triggering allergic reactions and plays a crucial role in the development and persistence of inflammation in allergic diseases. It binds to high-affinity receptors on mast cells, basophils, dendritic cells, and lymphocytes. Activation leads to acute bronchospasm and release of pro-inflammatory cytokines. Management. Medications are divided into long-term control for persistent asthma and quick relief for acute symptoms exacerbations. Long-term control medications. Corticosteroids, Most potent and effective anti-inflammatory medications. Inhaled corticosteroids, ICS, are used for long-term control. Block late-phase reactions, reduce hyperresponsiveness, inhibit inflammatory cells. Oral systemic corticosteroids are used for quickly gaining control or reserved for severe persistent asthma. Cromolyn sodium and nedocromyl stabilize mast cells, interfere with chloride channel function. Alternative treatments for mild persistent asthma or preventive before exercise allergen exposure. Poor oral absorption, administered by inhalation. Reduce bronchial hyperreactivity. Immunomodulators, omalizumab, anti-IgE, prevents IgE binding to receptors on basophils and mast cells. Adjunctive therapy for patients aged 12+ with allergies and severe persistent asthma. Inhibits activation of IgE already bound and prevents degranulation. Expensive and not first line. Leukotriene modifiers include LTRAs, montelukast, zafirlukast, and a 5-lipoxygenase inhibitor, Xiluten. Alternative, but not preferred, treatments for mild persistent asthma, Step 2 care. Can be used with ICS, but LABAs are preferred adjunctive therapy for patients aged 12+. Have bronchodilating and anti-inflammatory actions, but are less effective than inhaled corticosteroids. LABAs, long-acting beta-agonists salmeterol and formoterol. Bronchodilators with effects lasting greater than or equal to 12 hours. Should not be used as monotherapy for long-term control. Combined with ICS for moderate or severe persistent asthma. Preferred adjunctive therapy with ICS for patients aged 12+. Can be used before exercise to prevent EIB, but chronic use is discouraged as it can mask poorly controlled asthma. Not recommended for acute symptoms or exacerbations. Methylxanthines, sustained-release theophylline is an alternative, not preferred, adjunctive therapy with ICS. Mild to moderate bronchodilator. May have mild anti-inflammatory effects. Monitoring serum concentration is essential due to low therapeutic index. Inhibits phosphodiesterase and blocks adenosine receptors. Quick relief medications. Anticholinergics, ipratropium bromide inhibits muscarinic receptors, reducing vagal tone. Adds benefit to SABAs in moderate to severe exacerbations. Alternative bronchodilator if SABAs are not tolerated. Less effective than salbutamol alone in treating acute asthma. SABAs, short-acting beta-agonists salbutamol, levalbuterol, perbuterol. Bronchodilators that relax smooth muscle. Therapy of choice for acute symptom relief and EIB prevention. Rapid onset, 15 to 30 minutes, short duration, 4 to 6 hours. Systemic corticosteroids, used for moderate and severe exacerbations as adjuncts to SABAs to speed recovery and prevent recurrence. In adults and school-aged children, administering within 1 hour of arrival at ER can reduce hospital admission. Oral prednisone is as effective as 4 IM. Oral dexamethasone is also effective. Short-term use is often well tolerated but can cause side effects like mood changes, GI issues, and sleep problems. Short courses have been associated with sepsis, thromboembolism, and fracture. For acute asthma, a course of at least 7 days may be more effective than shorter courses, though 5 days may be sufficient. In children, a 3-day course is often as effective as 5 days, but 5 days may be needed for severe life-threatening cases. Salbutamol administration. Inhaler plus spacer or nebulizer. Inhaler with spacer is at least as effective as nebulizer in preschool children, viral-induced wheezing acute asthma, and adults, and equivalent or superior in school-aged children. Nebulizers increase risk of respiratory infection transmission and adverse effects. For salbutamol is generally reserved for severe acute asthma unresponsive to inhaled bronchodilators. Limited evidence on efficacy safety, protocols vary widely. For does not appear superior to inhaled. For is associated with increased risk of tremor and hypokalemia. Repeating salbutamol doses at intervals of 30 minutes or less may be more effective for adults who don't respond clearly to the first dose. For those with clear improvement via PMDI plus spacer, repeating more often than every 60 minutes may not provide advantage until full recovery. Oxygen therapy. Oxygen is used to treat hypoxemia, not breathlessness. Pulse oximetry is necessary to monitor status and adjust dosage. Goal is to achieve adequate saturation without causing hypercapnia. Adults with acute asthma and asthma-COPD overlap are at greater risk of hypercapnic respiratory failure. Drying of the upper airway is a potential complication. In adults, maintain SpO2 at 93 to 95%. High-concentration high-flow oxygen can significantly increase blood CO2. SANS guidelines recommend administering oxygen if SpO2 less than 92% or less than 88% for COPD, and titrating to 92 to 96%, 88 to 92% for COPD. Limited evidence for children. Targets may be as low as greater than 90% or greater than 92%. Recommendations vary. Humidified oxygen can be considered if needed, usually for longer than 48 hours or if nasal passages become uncomfortable dry. Humidified high-flow nasal cannulae, HHFNC, provides humidified high-flow air oxygen mix. Little evidence for use in acute asthma but appears safe. Reported feasible and safe in children with severe asthma in ICU. May be at least as effective as conventional oxygen therapy in children not responding adequately to initial bronchodilators. No published studies evaluate use in adults with acute asthma. Ipratropium bromide. In adults older adolescents with severe acute asthma in ER, combining ipratropium with SABA reduces hospitalization rates and improves lung function compared to SABA alone. Does not reduce hospitalization in mild or moderate acute asthma. Associated with a higher rate of adverse effects, tremor, agitation, palpitations, in adults compared to SABA alone. In children with moderate to severe acute asthma, initial treatment with ipratropium plus salbutamol significantly reduces hospitalization and improves clinical scores. For children already hospitalized, the combination is not more effective than SABA alone. The combination appears well tolerated in children. Chronic obstructive pulmonary disease, COPD. Definition. COPD is a preventable and treatable disease characterized by airflow limitation that is not fully reversible. The airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lung to noxious particles or gases. COPD is an umbrella term describing two main conditions, emphysema and chronic bronchitis. Gold defines COPD as characterized by persistent respiratory symptoms and airflow limitation due to airway or alveolar abnormalities usually caused by significant exposure to noxious particles or gases. Chronic bronchitis is a long-term inflammatory condition of the airways characterized by a persistent productive cough without other identifiable causes lasting at least 3 months per year for 2 consecutive years. Etiology. COPD develops due to extended exposure to harmful particles or gases. The leading cause globally is cigarette smoking. Other contributing factors include second-hand smoke, environmental and workplace pollutants. Occupational exposure includes gases, mineral dust, fumes, and solvents. Alpha-1 antitrypsin deficiency, AATD. A rare hereditary disease contributing to 1 to 2% of COPD cases. In developing countries, biomass fuels, wood, dung, crop residues, used for cooking are significant causes, particularly affecting women and children. Lung infections. Allergies. Low birth weight. Air pollution. Asthma. Gastroesophageal reflux. Recurrent respiratory infections. Chronic aspiration. Among COPD patients, 80% to 90% are smokers. 10% to 15% of smokers develop COPD. Symptoms in smokers depend on intensity and duration of smoking and baseline lung function, typically appearing after at least 20 pack years. 4% to 22% of chronic bronchitis cases occur in non-smokers. Genetic factors play a role, with links to polymorphisms on chromosomes 3 and 11p15.5. In children, chronic infection with H. influenzae, S. pneumoniae, and M. catarrhalis underlies protracted bacterial bronchitis, PBB. Pathophysiology. COPD is an inflammatory condition affecting airways, lung tissue, and blood vessels. Involves oxidative stress and imbalances between proteases and antiproteases. Emphysema involves destruction of alveolar air sacs, leading to obstructive lung function. In emphysema, irritants like smoking trigger inflammation, recruiting neutrophils and macrophages that release mediators. Oxidants and excess proteases destroy air sacs. Protease-mediated elastin breakdown causes loss of elastic recoil, resulting in airway collapse during exhalation. AATD causes emphysema due to a lack of antiproteases, making lung tissue vulnerable. AATD emphysema primarily affects the lower lobes, unlike smoking-related. The inflammatory response and obstruction decrease FEV1, leading to airflow limitation and impaired gas exchange. Hyperinflation occurs due to air trapping from airway collapse, causing elevated CO2 levels. As disease progresses, gas exchange impairment worsens, with reduced ventilation increased dead space leading to CO2 retention. Pulmonary hypertension may develop due to vasoconstriction from hypoxemia. Acute exacerbations are common, often triggered by infection irritants, leading to increased inflammation and air trapping. In emphysema, damage is beyond the terminal bronchiole, acinus, leading to abnormal, permanent dilation of air spaces and destruction of walls. This reduces alveolar and capillary surface area, impairing gas exchange. Inflammatory cells like macrophages, neutrophils, and T lymphocytes are crucial in emphysema. Macrophages release neutrophil chemotactic factors, LTB4, Illinois 8. These cells release proteinases, leading to mucus hypersecretion. Elastin is destroyed by an imbalance between elastase and anti-elastase, causing airspace enlargement. Cytotoxic T cells release TNF and perforins, destroying alveolar wall epithelial cells. Cigarette smoking exacerbates mucus hypersecretion, increases neutrophilic proteolytic enzymes, and inhibits antiproteolytic enzymes alveolar macrophages. In chronic bronchitis, exposure to irritants triggers mucus overproduction and hypersecretion. Inflammatory cells activate EGFR, leading to mucin gene transcription and excess mucus. Neutrophil-mediated elastase increases neutrophil activity, causing mucus hypersecretion and thickening of the epithelial cell layer, obstructing airflow. Excess mucus alters airway surface tension, predisposing it to expiratory collapse. Inadequate mucus clearance leads to infection and inflammation. Chronic cough and sputum production increase the risk of developing COPD. In children, initial insults, viral infection, pneumonia, weaken lung defenses, leading to excess mucus, reduced mucociliary clearance, and bacterial overgrowth, often in a biofilm. Management. Primary goals are to control symptoms, improve quality of life, and reduce exacerbations and mortality. Non-pharmacological approach includes smoking cessation and pulmonary rehabilitation. Annual influenza vaccination is recommended. Medications include bronchodilators, ICS, systemic glucocorticoids, parade 4 inhibitors, and antibiotics. Bronchodilators. Beta-2 agonists, relax smooth muscle. SABAs, e.g., salbutamol, for immediate relief. LABAs, e.g., salmeterol, formoterol, for maintenance. SABAs provide immediate relief and are used as needed. LABAs are used for maintenance therapy. Antimuscarinics block M3 receptors, preventing bronchoconstrictor. SAMAs for rapid relief as needed. LAMAs, e.g., tiotropium, for maintenance. Antimuscarinics are considered superior to beta-2 agonists for COPT management. Methylxanthines, used in maintenance therapy, e.g., theophylline, usually after LABA or LAMA. Relax smooth muscle, causing mild bronchodilation. Monitoring serum levels is essential. Inhaled corticosteroids, ICS, often used in combination with LABAs and LAMAs to reduce inflammation. Combination of ICS plus LABA is more beneficial than either alone. Increased risk of pneumonia with ICS treatment. Systemic glucocorticoids, reserved for managing acute exacerbations due to side effects. Phosphodiesterase 4, parade 4, inhibitors, reduce inflammation by inhibiting intracellular camp breakdown. Roflumilast is used for severe COPT and decreases exacerbations. Antibiotics may reduce exacerbations, e.g., azithromycin, often triggered by bacterial viral infection. Supportive therapy. Oxygen therapy. Routine supplemental oxygen does not improve quality of life outcomes in stable patients. Continuous long-term oxygen therapy, greater than 15 hours per day, recommended for severe resting hypoxemia, PaO2 less than 55 mm of mercury or SpO2 less than 88%. Aims for SpO2 of 88 to 92% in patients at risk of hypercapnic respiratory failure, compared to 94 to 98% for most acutely ill patients not at risk. Intermittent oxygen for desaturation during exercise can maintain SpO2 greater than 90%. Ventilatory support, non-invasive positive pressure ventilation, NPPV, reduces morbidity mortality in acute respiratory failure. Should be the first mode of ventilation for COPT exacerbations with respiratory failure if no contraindications. Improves gas exchange, reduces hospitalization, decreases work of breathing, enhances VQ matching, and improves survival. Intubation mechanical ventilation needed if NPPV is ineffective. Croup. Definition. Croup is a common respiratory illness of the trachea, larynx, and bronchi. It can lead to inspiratory stridor and barking cough. Includes laryngotracheitis, laryngotracheobronchitis, and laryngotracheobronchopneumonitis. Affects about 15% of children, usually between 6 months and 5 to 6 years. Etiology. The etiology is predominantly viral, though some cases are bacterial. Viral causes. The parainfluenza virus, types 1 and 2, is the most common cause of viral croup or acute laryngotracheitis. Other viral causes include influenza A and B, measles, adenovirus, respiratory syncytial virus, RSV, and rhinovirus. Recurrent episodes are often called spasmodic croup, caused by the same viruses but without signs of infection. Allergy or airway reactivity may play a role. Bacterial causes. Laryngeal diphtheria, caused by Corynebacterium diphtheriae. Bacterial tracheitis, laryngotracheobronchitis, and laryngotracheobronchopneumonitis often start as viral infections that worsen due to secondary bacterial growth. Common bacterial pathogens include Staphylococcus aureus, Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. Risk factors. More common in males than females. More common during autumn and spring. Pathophysiology. Croup leads to swelling of the larynx, trachea, and large bronchi due to white blood cell infiltration. Obstruction caused by swelling and inflammatory exudates develops and becomes pronounced in the subglottic region. This is the narrowest portion of a child's upper airway. This swelling partially obstructs the airway, significantly increasing the effort required to breathe. Severe obstruction causes turbulent and noisy airflow known as stridor. Stridor in children with croup occurs from mucosal and submucosal edema of the subglottic portion of the airway. It is crucial to exclude other causes of stridor, such as foreign body aspirations or ingestions. Management. Treatment is based on severity. Children with croup typically need to be kept as calm as possible. Oxygen should be administered via the blow-by method if needed to reduce agitation. Medications. Steroids, corticosteroids, dexamethasone, budesonide, help in faster symptom resolution, reduced return to medical care, and shorter hospital stays. Dexamethasone is more effective than budesonide for symptom improvement. Given routinely. Adrenaline. Nebulized adrenaline improves symptoms within 30 minutes, but effects may wear off after 2 hours. Recommended for moderate to severe croup. Prolonged observation, 4 hours, is recommended after nebulized adrenaline. Concurrent treatment with oral steroids may be beneficial. Antibiotics, reserved for suspected primary or secondary bacterial infections. Vancomycin and cefotaxime are recommended for secondary bacterial infections. Antiviral neuraminidase inhibitors may be used for severe cases associated with influenza A or B. Treatment by severity, Wesley score. Mild croup, less than or equal to 2 single dose of dexamethasone. Moderate to severe croup, 3 nebulized adrenaline in addition to dexamethasone. Supplemental oxygen for low oxygen saturation. About 0.2% of children may need endotracheal intubation for respiratory support. Use a tube 1/2 size smaller than normal. Other treatments. Inhaled hot steam or humidified air has not shown significant improvement. Cough medicines containing dextromethorphan or guaifenesin are discouraged.